Chair, we'll go on to the last presentation of this session that features novel drugs and devices for heart failure. A peek into the future, I'd like to invite Dr. S. Rama Krishnan, Professor of Cardiology at the All India Institute of Medical Sciences, New Delhi, for the next 12 minutes. Professor Rama Krishnan, please.
Thank you, Padmanabhan. At the outset, I would like to thank the chairpersons and the organizers for bringing me here. I think for those of you who don't know, I think in fact, I'm a Georgian. I did my MD from Lucknow, KGMC Lucknow. So I have fond memories of Lucknow. So it's always a privilege to be here. I think when you give us such a topic, it's novel drugs and devices in heart failure, a peek into the future. It's about selling the dreams. So I will be selling the dreams of major companies that are trying to do a lot of things, but I assure you that I won't let you sleep for those dreams. Okay, so now moving on, I think why we need novel therapies and newer drugs, because there is a lot of pending requirement is there. Despite all these therapies, all these major therapies that has come, their 5-year survival is roughly around 50%, number one. And in Indian scenario is further bad. We are doing terribly badly when it comes to heart failure. Our heart failure mortality is high, our patients are younger, still they are dying faster. Our use of guideline-directed medical therapy is extremely poor. So these are the major reasons why we need newer implementation, newer guidelines. And these are the various things that have happened in heart failure, and it's emerging as one of the most happening field in cardiology now. TAVI in interventions and possibly heart failure therapeutics is a major and most happening. Nobody is trying to invent a new hypertension medication. I think everybody is working on heart failure now. And I think this slide you have seen before, these are what is available here. But something that I'm not going to talk, so many things are happening. Like for example, in vaccination, in telemedicine, in artificial intelligence, in remote monitoring, and various therapeutics in optimizing whatever is available already, in cardiac rehabilitation, and after a long time we had a very major trial from India which showed the utility or lack of utility of yoga in heart failure therapeutics. So I would like to divide it into various parts, the novel therapies. One is the expanding indication or available drugs, the newer drugs that are trying to get established themselves, and the drugs that are already getting established. And then we'll move on to the various devices and the mechanical circulatory support that are available. So moving on to expanding indications of RNE, these are the various major RCTs that have happened after the paradigm. Paradigm is a big paradigm change in cardiology. I think every 10 years we get one major drug in cardiology. That was possibly Novax 10 years back, then RNEs, and possibly now SGLT2 inhibitors. So it's been happening, like beta blocker, AC inhibitors, the history goes on. Every 10 years we get a blockbuster, and one such blockbuster was RNE, and they try to do it. Now once we get a blockbuster, we want to do it everywhere. So you get a blockbuster movie, they want to put it in all languages in India. So same thing happens. They want to try it on all indications. Unfortunately, rest of the other indications, they all fail. So except for slightly decompensated heart failure, RNEs don't possibly work. They are very well indicated in heart failure with residual fraction, nothing beyond that. And then came the SGLT2 inhibitors. We all know how do they work. And I think they are possibly a revolution. And they initially started off as a diabetic drug. Then they thought it's a cardioprotective drug, but now realize that possibly it's a number one indication is going to be heart failure. They are first number one, a heart failure drug, then they are going to be a cardioprotective drug, and then possibly the last action is going to be a diabetic drug. So that is how the history may change. And these are fantastic. Like, these are some of the numbers that are here in heart failure. They are really, really amazing. So I think for one information, I think Indian physicians are very good in taking up newer drugs, and that is proven now. And now Indian cardiologists, the number one prescribed medicine in Indian cardiologists is a SGLT2 inhibitors, not a statin. That is the recent data that has come up. So there are expanding indications. Clearly the Emperor Preserved is possibly has proven that possibly this is the first indicated drug where a drug that is shown to work in HPEP. So that's a clear-cut indication, and now, as I told you, even without diabetes, you can easily prescribe patients who have uncontrolled heart failure. So these are clearly indications where it's important. So what about inhibiting both the things, like SGLT2 as well as SGLT2? So you can inhibit both the things and can potentially get more benefits, and the drug that is available is the sotagliflozin, which has been tried in this trial, and there also most of the heart failure things have improved. So major trials are ongoing with this, both event reduction as well as heart failure. So another thing that has been proven now recently, that trials have proven, a double-blind randomized control trial has proven, is the utility of the ferric carboxymaltose in iron deficient patients who are discharged with acute heart failure. So this is another thing, that nobody should go home without a hemoglobin and ferritin, those who are admitted with heart failure, and such a simple therapy, and possibly this one therapy should work more in Indian patients. We all know that. So what are the new kids of the block? So there are a few new kids of the block. One is very sick bird. So very sick bird increases the cyclic guanylase activity and improves the myocardial as well as cyclic GMP primarily, and improves the myocardial and vascular function. So Victoria is a very large trial that included 5,050 patients of symptomatic chronic heart failure with class 2 to class 4 with a ejection fraction of less than 45% on all available heart failure therapies with a worsening heart failure event. And this is what it showed. So the results, even though it's a relatively a smaller trial compared to the other large mega trials, but still the results are very good, and there was a cardiovascular death and first heart failure hospitalization both reduced, even though the individual parameters did not differ, but an annual NNT to composite endpoint was only 24. So this is another important agent that has come into the picture. Another important agent that has trying to get established itself is the omecamtiv mecarbil, which is a cardiac myosin activation. So it's a newer thinking, like where I think we have failed with digoxin, for example. I think some discussion was happening about digoxin. So digoxin, there are some data suggesting that use of digoxin is associated with increased mortality. But these are all observational studies. There is nothing is conclusive as of yet, and there's a very large randomized control trial which is going on by Indian centers, by India. I think you will get the results of digoxin. But what is the biggest difference is here, even though we are trying to increase the contractility, but there is no change in the myocardial oxygen consumption and no change in LV dP by dt. And that is why possibly it resulted in a positive trial. This trial is a galactic heart failure trial, which showed that the first heart failure event and cardiovascular death reduced. The symptom benefit also reduced. Again, it's no significant reduction in components of primary endpoint was there. And there are various other therapies that are in testing, various phases of testing. I think if I put that slide, I can put 20 slides on this. There are various therapeutic agents that are going on. These are the major things that are in stage 3 or stage 2 of development. And some of them are serelaxin and SERCA2A are something very interesting, where they try to change the, increase the cardiovascular contractility again. So, but still, despite all these efforts, I think many of our patients ultimately end up requiring a transplant. So which I think hardly ever happens in this country, even though the numbers are promising now, especially South India. I think it has taken off really well, but still the number of patients who need a transplant and the number of hearts that are available is extremely limited. So to bridge it, we have various kinds of the LVADs that are available now. So which has become a kind of, they are becoming available in our country and they are being utilized now. So I think before we say that advanced heart failure who are waiting for a CPR to be started, they all should be considered for expert evaluation by an advanced heart failure therapist, and they should be considered for a LVAD therapy. And these are the various options that are available: bridge to transplant, or a destination therapy, or for recovery. So these are the various that are available in the pulsatile devices, continuous flow devices. These are the various approved devices. I won't be going into detail, but what is practically that has become available in our country is IABP has become available, ECMO has become available, tandem heart is available, and then you have CentriMag and Abimed, they are becoming available in some parts of the country. So for long-term therapeutic actions also, we have started getting HeartMate 2, and possibly we'll get HeartMate 3 in future. So HeartMate 3 is a centrifugal flow, fully magnetized pump, which leads to less shear stress and possibly leads to less thrombosis, which was proven in the Momentum 3 trial. So this showed that the HeartMate 2 is well established LVAD. It works, but problem is that thrombotic events were slightly higher, and HeartMate 3 clearly has shown the utility that we can achieve all of them without less of thrombotic rate. Coming to HPEF. HPEF is a very heterogeneous population. It's not possibly one disease. I think it's a heterogeneous disease where I think except for SGLT2 inhibitor, there is no other therapy that has been shown to have benefit. Maybe some benefit is shown in some subgroups with ARNI and some with aldosterone antagonist. And so various, then they have now gone overboard about various drugs as well as some innovative therapies. We are trying to unravel the various pathogenetic mechanisms that are in play in HPEF. So some of the pathological mechanisms are the LA dilatation, progressive LA dilatation. It's a kind of an LA cardiomyopathy kind of a thing that is happening, and then that leads to pulmonary congestion. There is a altered LV hemodynamics, and there is exercise intolerance because of autonomic imbalance. All these are being targeted by various therapies like atrial shunts, LV expanders, MCS devices. I will come to that. They are very interesting thoughts, and then how to modulate the autonomic function with various stimulation devices. So the atrial shunts, I think the first we thought was doing an atrial septostomy, do a atrial stenting. It all started with that. Then we had the AFR is a very simple occluder that you can easily say that's a kind of a ASD device which has a nice hole inside. So they all figured out how much that hole should be. It should be either 5 millimeter or 8 millimeter. All those have been sorted out. Now it's in real use. The other one that is available is, this was put in India also. Some patients, they have benefited with this. And then we have Corvia as well as B-valve shunt. They have become in various phases of development. But interesting thought, once you put a device, there is a chance of embolism, there is a chance of cyanosis. Then people thought, why don't we create a device put a device between LA and CS? So you obligate getting into the right side, right atrium at least. So that I think was an interesting thought, and the earliest trials are going on. So this is another thing that has become a reality, that the Corolla device, which I think needs, there are various other types of LV expanders were tried, but they all were very cumbersome surgeries. Either they needed a full open heart surgery, but this particular device, Corolla, can be implanted with a on pump, and can be with a minimally invasive surgery can be implanted. And the trials are going on to make the LV expand better. And various types of stimulation therapies which were developed for various other indications have become more established. Like for example, getting established, the various trials are going on. The Barostim Neo, the baroreceptor activation therapy, the cardiac contractility modulation, and then you have the vagal stimulation devices. All of them are undergoing various stages of development in heart failure. Coming to the MCS, that are the mechanical circulatory devices, specifically for, I will just finish with one slide. So the one that is, can I have my slides back and just come to the last slide? So the MCS is actually an atrial pump device. So you put the pump in the atria and then you device. And there are various other specific conditions that have come up with mavacamten, the transarretin, you have tafamidis and patisiran and myocarditis. I think with this we will get a lot of things. But ultimately my take home message is, these are all very good dreams. Like politicians selling dream, I was selling dream for 12 minutes, but let us come to reality. The reality is we don't treat our heart failure patients properly. Less than 20% of patients receive all these guideline medicated drugs like beta blocker, AC inhibitor or ARNI, SGLT2 inhibitors and MRA. Our request is that every patient who comes to your OPD, who leaves your hospital, should be on all these guideline directed medical therapy. Thank you very much.
Thank you, Dr. Rama Krishnan.
Yeah.
In a short period of time, you have comprehensively covered both drugs and devices, their future. My question may be weird. Where do you find the SGLT2 as the primary prevention in all diabetics and all high-risk patients of hypertension with target organ damage, CKD or post-MI?
I think, sir, secondary prevention post-MI is very clear. I think if you look at the number needed to treat, I think that is
All
the
patients.
maximum. All patients should be on. So then I think high-risk diabetes, I think nobody will have a problem. But if you have a young diabetic who is recently diagnosed, whether that patient must be on SGLT2, I'm not sure. And I don't think we have the answers in the literature also.
Okay, that's...
Any question or comments?
Dr. Ramashan, one question. So when we all were under the impression that the cardiovascular therapeutic armamentarium had climaxed and it had reached its zenith, then came the SGLT2, which has shown all-cause mortality reduction, which is very, very rare. I think the last drug which had shown all-cause mortality was simvastatin, if I am not wrong. So do you think we have further room for one more drug?
I think so. I think we cannot, nature and humanity are ever supreme than individual human minds. So I think we will definitely keep on getting some drugs, but it could be some different aspects, like possibly we have reached the therapeutic limits of the RAS pathway that we were thinking about. And I think heart failure, I think there are so many things that are possible, especially with now the so many mRNAs coming up. I think we will have definitely, I feel that some mRNA drug will come up in heart failure recently, like very soon.
Okay, that's all the time that we have, Mr. Chairman. We'll move on to the last